had the privilege of judging the student posters. And so I'm here to announce the winner, which is Demi P. No one would tell me how to pronounce the last name, so I apologize. Is she here? Where is she? Okay. She's a student in the UBC program. So congratulations. And Morris tells me the details are in the envelope. Okay. And you don't have to open it in front of everybody.
So thank you very much, Sherry. And so we arrive at the final session. Congratulations to all those who've made it to the end. I'd have to say that it's, speaking on behalf of you, perhaps, it's been just remarkable to hear such a, I think it was Greg who referred to it as an all-star lineup. It's been delightful for me to remember why I retired. But I would like to thank Morris and others to give me this one opportunity to come back and remind myself of that. So, great. We're in for a great panel here. Unfortunately, we are missing one of the panel members, Andrew Buzzardi from Ontario. The reason being that, as I think there were intimations of earlier on in trying to find where research fits in the policy process, they march to a different time drama. And the demands of the Ontario Ministry of Health on Andrew just at the moment are greater than the desire that he may have to come and, which we know was great, to come and present to us on some of these issues today. So we are left with the eminent crowd that you see on the stage right now. John Lavis, who is the Chair in Evidence-Informed Health Systems, and 5 other titles, which just goes to tell me with 5 other faculty appointments, he must love faculty meetings. You can look in your program for what those are. Heather Davidson, who has for 21 years worked in the BC Ministry of Health at increasingly senior levels. That is definitely a testament to her persistence, and I wouldn't be surprised if she was a marathon runner as well. So welcome, Heather. And of course, His Eminence himself at the end, Bob, who, whether we liked it or not, we knew this would happen, so he will get the last word. So we officially gave it to him rather than him just taking it. So let us start off with the first presentation from John Lavis. Thank you, John. Oh, and by the way, I'm Jonathan Lomas. Sorry.
Thank you very much. I'm just going to start with a brief comment about Bob's influence on my professional career, which has been profound, but I guess indirect, which is the interesting piece. So you heard the story about how Bob got a letter from a young gentleman at the University of then, it was called the University of Western Ontario, Greg Stoddart. Greg ended up going off to McMaster to a department filled with clinical epidemiologists and biostatisticians, and somehow carving out a space and convincing people that this was an area that they needed to do more of. And not just health economics, but health policy analysis. And he, Greg, and Jonathan Lomas created a place at McMaster that by the time folks like me came along, we could do what we wanted to do. We could systematically study politics. We could transparently report that. We could distinguish the folks who are out there making purely values-based assertions from those of us who are trying to bring much more critical approaches to the study of politics. So I'm really grateful to Bob for what was effectively setting into effect a chain of events that created a space that folks like me could thrive in. And many of my colleagues at McMaster know that story. They know the lineage traces back up through Jonathan and Greg and ultimately to Bob. So I'm very grateful for that space. It's made a huge, huge impact. I also just wanted to say that the U.S. health economists took such a hit yesterday. I couldn't let it go without saying that of health economists with whom I'm sure Bob disagrees vehemently, but perhaps not as strongly as Mark Pauly, and that's Joe Newhouse, was my kind of guardian during my PhD at Harvard and let me go off and do most of my courses in the Gov department and bring great people like Paul Pearson and others onto my thesis committee. So they might have ideas that we think are pretty awful, but they can also be pretty good eggs. And I'm very grateful to Joe for creating a space in that environment for me to do my stuff. The point with this panel was to put the pointy-headed academic who studies politics on the panel with the folks who live it, both as a senior public servant in the case of Heather and as a political advisor who whispers directly into the ear of the health minister. And as you heard, unfortunately, we lost Andrew. So you're hearing two pieces of the take on this issue of what are the critical factors that influence whether policy change actually happens. Some of you might recognize the title of the talk is coming from a book that was lead authored by Harvey Lazar. I think I've only presented it once, and I'm actually going to go through the methods, and that's in part, I was going to take it out, left it in, but yes, there were times yesterday where I kind of felt like we were at a Bernie Sanders convention, and so I wanted to point out that you can also use rigorous methods to get at some of the same issues, and I'm going to see if I can convince you about that with this talk. So a little bit of background to this effort that sucked up many of our hours of work over a long period of time was this perception that the system had been frozen in place since around 1970, by which time virtually all of the medical insurance plans had locked into place in provinces across the country. Hospital insurance had been locked into place the decade before. And we wanted to know, is that the case? And we also wanted to know, if it is the case, why is it so hard to achieve substantive reform? So we knew there were examples of where reform was happening, but was it really the case that things were frozen, and if so, why? And what is such a departure, perhaps, from a lot of the conversation over the last day and a half, we tried to, and people can contest whether this is possible, we tried to be neutral about whether reform was desirable or not. And we tried to be neutral about which reforms are best. And I'm going to talk to you about how we assessed reforms, what we used as our comparator, but it wasn't a sense of what we thought were necessarily the ways to go. So the methods, an empirical study of policymaking processes, we ended up with 30 cases, 6 policy issues in each of 5 different provinces. Those provinces were selected because they were different in a number of respects. And interestingly, over this very long study period, some of them moved from have provinces to have not, and ultimately since then some have moved back and vice versa. But we studied Alberta, Saskatchewan, Ontario, Quebec, and Newfoundland and Labrador. And we were mostly focused on a 14-year window of time between 1990 and 2003, but we extended it up to 2011 with some additional work. So I'm going to quickly walk you through the methods because although some people have come to similar conclusions as we have in some of their comments, I just want to explain how we got there. So 4 steps in the process. The first one is pick the policy issues for study, because you could go off and just select areas that prove your point, but we wanted to take a more robust approach and be able to back it up. So we used a sector-specific taxonomy for policy domains. And we identified 6 policy issues where reform had been attempted or undertaken, and we did that based on both literature reviews and interviews. So we picked one from the governance arrangements category. That governance arrangements to us meant who gets to make what types of decisions, what can docs do versus nurses, what does government do versus regions, that type of thing. Financial arrangements, where does the money come from? How does it flow to organizations and individual professionals? Are patients incentivized? How do we make decisions about purchasing products and services? And we picked 2 here, needs-based funding for regions and alternative payment plans for physicians. I failed to mention we picked regionalization on the governance side. On the delivery arrangements side, we picked for-profit delivery of medically necessary services, so competing with our dominant approach or exclusive approach in the case of acute care, not-for-profit hospital provision, and we also looked at waitlist management. And then from the program content side, we looked at prescription drug plans. So the idea of providing a prescription drug plan, we heard a lot yesterday about pharmacare, and we wanted to look at whether innovations of that type were happening. And then we wanted to figure out a policy puzzle. So what was most interesting to us was when some provinces went down one path and other provinces went down another path, and we wanted to understand why. And we looked both at policy decisions where people decided to do something, but we also looked at cases where it kind of got close to maybe people thinking about doing something and they never actually made a decision. It's just time marched on, nothing happened. And then other times when there was an explicit no-go, where we thought about it and we're not going to go down that path. So that's how we picked the policy issues. Next, we selected the analytical framework to examine agendas and decisions. So you heard Danielle mention this. You also heard Ted mention Kingdon, the idea that just to get attention among politicians, you need a problem or you need political events. But if you want to make change happen, you need a problem, you need a viable policy to address it, and the politics have to be right. So that's the question of what drives whether governments decide to take action. We also, though, wanted to know, once they decided to take action, what did they actually do? And that's where I'm going to focus my time in terms of what we found, that piece of it. And here we used a simple framework: institutions, interests, ideas. And then we also allowed for external factors, things happening outside health, political changes, economic changes that have spillover effects into the health system. And you'll see a little bit more about what we considered institutions, interests, and ideas there. On the ideas front, maybe importantly, we distinguish knowledge or beliefs about what is. That's where the research can come in, and the values about what ought to be, which we've heard a lot over the last day and a half. So those were the frameworks, but I'm going to focus more on the policy decision side. Next step was collecting and analyzing data related to the agendas and decisions. Huge amount of documentary analysis. You'll see as a reflection of how long ago some of these things happened, we actually went back to old telephone directories to find out who was in positions like Heather at the time, so that we could go back to the right people to figure out what happened. We scrolled through all kinds of parliamentary debates in Hansard. We looked at LexisNexis, all the usual places, to try to figure out what happened. And we came up with timelines of key events, which was really helpful at pulling the rug out from under people. If you do elite interviews and you're sitting in front of someone like Bob Ray, very sophisticated politician, you better be prepared to challenge him or her on certain things that they say. So we had a timeline ready to go. So if they argued the order happened in a certain way, we could politely push the timeline across the table and say, well, actually, that's not what our media and documentary analysis say. Here's what we understood to happen in what order. Can you explain why that happened? And then the huge process was the interviews, trying to get time with the politicians, with the public servants, with the political advisors, with the interest group leaders, to try to figure out exactly what happened. We ended up with 238 interviews in total. And then, as I mentioned before, we used Kingdon and the 3I framework to study it. And then the piece that Harvey Lazar deserves a gold medal for was trying to make sense across this. So a lot of comparative work has a bunch of people that go off and do their work, and then someone at the end of the day, kind of a big box that says magic happens, and then you end up with these big dramatic conclusions. But Harvey wanted a uniform analytic approach across all of the cases. So he identified some additional codes. We coded things according to whether it was pro-reform, and here's the standard that is very important for you to understand. The standard was what the gray literature said. And that's largely a literature that's written by many of the folks in this room. What have the big national commissions said? What have folks like Bob Evans written? What has Stephen Lewis been saying? Because we wanted to know, what did the great and the good say that the system should be doing? So that was how we measured what we called pro-reform. Anti-reform was going in the opposite direction. So you'll have seen one case was for-profit delivery, and we wanted to, and there were people out there at the time that were actively promoting that. And so we wanted to know, were they anti-reform? That's counter-consensus reform, my apologies. Anti-reform would be attachment to the status quo. We love Medicare, as many people have said over the last day and a half. Don't change anything, don't upset the apple cart. And then we looked at the extent of reform. And it's always tough to attach labels that are kind of quantitative almost in nature to the extent of reform. Harvey felt very strongly we needed to do this. We ended up with these 5 measures, from none up to comprehensive. And then this Herculean task, applying the codes, seeking feedback, and iteratively revising the codes. So what did we find? All of that was a long-winded way of saying this was a hugely labor-intensive process. We ended up with, of the 30 cases, 7 of them that were at the high end of that scale, comprehensive or significant. 17 of them were at the opposite end, none or limited. And then the other ones fell into that middle category, not one way or the other. They were the moderate ones. So we didn't have that much reform over a 14-year period where all of the folks that were at the leading edge of debates in this domain were saying we need reform, and we saw relatively little of it. So then our question was, what variables explain the 7 large reforms, and what explain the 17 status quo cases? So for the large reforms, the 7 cases, the only big pattern that we found in the findings in 5 of the 7 cases was 2 things seemed to matter: what we called the electoral process and a perceived fiscal crisis. So what we had labeled at the beginning, external factors, stuff outside the health system. And the big thing on the electoral side was a new government or a government leader. A new political party comes into power, or there's a change in the head of that governing party. And during the campaign, either for the election or for the leadership of the party, there was a commitment to reform during the election period. Once they were elected, they appointed a champion, and the policy was announced in the first half of the mandate. So really critically important that the big decisions were made at the political platform development stage, and then because they were successful, they were able to move on it. And that, combined with the perceived fiscal crisis, meant that the big reforms could happen. So the interesting thing to us was, it's not all of these debates that happen in the health system. It's the outside stuff, the changes in the political actors and the fiscal crisis, perceived or it could be real, that has the big impact. And what about the status quo? Because that's where we saw most of the action. Mostly, things weren't happening. Now, Harvey, we had many fights about many issues related to how to execute this study. Harvey distinguishes, in a way that makes me a little bit uncomfortable, insider interests and outsider interests. And the depressing thing is the outsider interests are the very citizens that the system is meant to serve. The insider interests are typically the docs and to some extent other public interest groups. So the insider interests, especially the medical associations, resisted, slowed, and shaped reform. So they had an effective veto on any change that affected their freedom as individual physicians to choose their preferred remuneration mechanism. And that came up in both the regionalization case, and in the alternative payment plan case. They had a near veto on any change that affected their clinical autonomy. Don't you dare tell me that I have to submit waitlist data and take patients in the order that some centrally derived algorithm tells me. That is my clinical choice to make. But medical associations weren't all powerful. They were less successful when its direct interests were not heavily affected. So, for example, the form that regionalization took in Alberta and Saskatchewan, largely not directly affected by medical associations. The outsider interests are the public interest groups or public opinion. And for the most part, these were the conservative forces on the side of protecting the Medicare legacy, and they were unsuccessful in efforts to extend that legacy to other areas like pharmacare or to home care. So public interest groups, public opinion pressure came into play really only on decisions that touched on things, not surprisingly, that had a more direct impact on patients. So how wait lists were handled, or whether they had access to subsidized prescription medication. So in Alberta and Saskatchewan, public interest groups or patients put a lot of pressure on governments to act on wait times, put it onto the government agenda. In Alberta and Ontario, they could not prevent privatization from getting on the agenda. Privatization here meaning moving from not-for-profit to for-profit delivery of acute care, but they did slow and alter the type of reforms. And in Ontario, AIDS Action Now, an activist group, during a time of incredible numbers of deaths among people living with HIV, pushed successfully for the introduction of what became the Trillium Drug Program. So that was a case of where they made a big influence on what, at that time, Bob Rae was willing to consider doing in Ontario. Other variables are important, and one of the problems sometimes with analyses is we don't think about all these other factors. We zero in on our preferred choices, but other things mattered a bit. Joint management committees, that's where we give docs a very privileged seat at the policy table along with government. Many provinces have them. Ontario calls it the Joint Services Committee. They were ramping up, but not yet fully functional. Canada Health Act, more symbolic than binding, and that's come up a few times over the last little while. FPT relations diverted attention to fiscal federalism instead of healthcare reform, something that's been a big shift in the last while. Under Harper, we didn't have those debates. It was pretty clear that the provinces were really responsible for healthcare. And policy networks formed, but mostly around more technical issues. So stuff was going on, but it wasn't as influential as these other things that mattered. On the ideas front, egalitarian values, which is a lot of what we've heard over the last day and a half, continued to reinforce the status quo rather than challenge it. And they played a larger role at the agenda-setting stage, getting governments to pay attention to issues, but not at the end of the day in terms of what actions government ended up taking. And knowledge or beliefs, the stuff that those of us who are researchers care about in significant part, played a larger role at the policy choice stage. So once folks decided to act, then they might start to look for evidence that might inform a pathway forward. So the bottom line, in a nutshell, 2 critical factors. So not necessarily success, because critical success factors, because as I mentioned, we were agnostic on the issue of what was good, but the 2 critical factors, the new government, coupled with the fiscal crisis, drove the large reforms. So my question for you is, what do we do with that? The one thing that we have come up with at the McMaster Health Forum is we now offer a free rapid response service to any political party when they're developing their electoral platform before an election. Because if we can influence that campaign commitment, those people who are successful at least are going in with reasonable ideas that have some backing with the best available evidence. But what else do you think could be done to deal with this fact that the big changes happen when we've got new governments, new leaders that explicitly fought a campaign and won on the basis of particular reforms? And on the interest side, a lot of kind of doctor bashing in the last day and a half, but how do you engage them? So what we've tried to do at the forum is to partner with the medical associations explicitly on topics that they care about as a way to get them engaged in discussions based on research evidence about what should drive health reform. And to their great credit, in my home province of Ontario, the OMA is seriously engaged in that. And if they do that on some issues, the ones they've asked us to take on for them, end-of-life care, and now how do we better deal with chronic disease in the system, it's much more difficult for them in other public fora to disregard the evidence and to argue purely based on their material interests. So that's an effort that we've made. But my question to you is, what else do we need to do if medical associations are such a significant damper on reform? What would be other ways that we could engage them? And then on the public interest group side, Danielle flagged this yesterday as an issue. What do we do about the fact that, and Colleen did as well, what do we do about the fact that so many people in the health research community and in the broader community of folks who are committed to a system that functions well for citizens resist reform? They're afraid to talk about changes to the system for fear of damaging it. So just a final slide, acknowledgements. The credit for this huge initiative goes to Harvey. You'll see the folks who ran the other provincial case study, CIHR. Thanks to Robin and her predecessors, Morris and Colleen, that's what got us to this. But let me just come back to, in a nutshell, that's what we took away from this labor of love that went on for a long period of time. My question to you is, if you buy that, what does this mean for how we move forward?
Thank you, John. So the way we're going to organize the session after John and Heather, we'll give a few minutes for folks in the audience to engage with them on the specifics around their presentation before we'll go into a more general discussion after both of them have presented. So this is the point at which those who have some answers to John's questions or those who have other questions, please now, at this point, go to the microphone if you wish, or you can save it for the more general discussion. Up to you.
Questions, comments? Greg.
Greg Stoddard. John, I know you've developed leading-edge institutional responses to research transfer, and I'm going to suggest meekly that have you got the targets wrong? And I'm going to try to link some things together, because I don't think Danielle ever got a full answer to her question. And I'm not sure that Robin ever got a full answer to her question about, well, what should we be doing as funding agencies? I know that Jerry was saying when you have this set of problems and challenges in financing and funding, the first step is really to make sure that the public understands. Colleen was saying, we're not going to have much chance at this unless the public understands that the Canada Health Act has both strengths and weaknesses, and then we can go forward. So we've spent all this time trying to do research transfer to clinicians, to policymakers, to bureaucrats, to politicians, and yet we also have heard that most politicians want to lead from behind, right?
Yep.
So should we be focusing much more on trying to, people like the people in this room, and there are some exceptions, Ted, Michael Rackless, Bob, people like that have made part of their career trying to get things out in terms of understandable sound bites to the public. But should we be changing the target or the balance of the target in research transfer? And should we be trying to go to the public much more to set the preconditions for things like political parties or other people setting agendas?
Yep.
Have we got the target right?
Yeah, no, so great question. I think I've been guilty, more than many, of not realizing the importance of engaging them. I think some of what we've done to try to head in this direction is try to push for much better reporting. And so for a number of years, we lost the reporter to Vox, unfortunately, but for a number of years, we had a partnership with Julia Blues from McLean in the Medical Post, and she had a column called Science-ish, the most highly read column. The only week she ever got bounced off the top read list was when, I can't remember their names, Prince William and his wife, whatever she is, Duchess of Cambridge, came to Canada. Otherwise, it was the most top-read thing. And what she would do was every week she'd try and find public statements by health leaders. It could have been Stephen Lewis. It could have been the CEO of a hospital. It could have been the Minister of Health in Ontario. And she'd look to see whether there was evidence underpinning the statements that they were making about the system. And that's a way of upping the game. Another way of upping the game we've tried to with McMaster Optimal Aging Portal is do a number of things that try and put evidence in language understandable to citizens. Evidence summaries that report evidence that's actionable, blog posts that bring it alive in very concrete ways, a web resource rater that tells you that if you go to, for example, Dr. Oz, it's mostly bullshit, it's not based on science. If you go to other places, there's fantastic stuff out there, and so you should know which are the good ones. And we run a Twitter feed. Every morning at 9, we run a search of media coverage on health and aging issues the day before, and then we get out the evidence within the same news cycle about what the evidence says. But we're more doing it right now focused on issues about people's own health and less about how to engage them in the broader system. And I guess the other thing that we're doing is we've learned that it's hard to engage citizens in deliberative processes that bring elites around the table, which is something we do through our stakeholder dialogue. So we now prepare citizen briefs that walk citizens through what do we know about a problem in the system, options for addressing it, and implementation considerations. And then we bring ethno-culturally, socioeconomically diverse groups of citizens together to talk about what do they think should happen, and we try to extract from that the values that politicians, we think, should be considering when they try and drive reform. So we're getting there, but we don't have all the tools in play like we do and have had now for 5 years to help stakeholders make better decisions and policymakers. So I think you're right, we need to, in part, refocus.
We'll go to Nora Lou at that microphone, the two at here, and I'm afraid we'll have to cut it off for that, but there will be more chance for folks when we get into general discussion. So, Nora Lou.
Thanks, John. And I think what you guys do is great work. What I think we also need to be doing, though, and this is not something which I ever thought I would get involved in, except that I was always irritated by what I would read in the paper about how they would always get the evidence wrong. And so we started Evidence Network, thanks to Robin, CIHR, Christina Weiss, Research Manitoba. And it has been remarkably effective. If you can get academics to realize it's worthwhile to write a 650-word summary, not saying more research is needed, but what have you actually found from your research, and we focus on the fact that this is evidence-based. We had almost 900 commentaries, op-eds published in Canadian papers last year. And a lot of them were in Globe and Mail, Toronto Star, a number of people are in the room. And it is remarkable the kind of response which you get from policymakers. My favorite one was we had an inquiry of a young woman in care who died. And they had a Sinclair inquiry looking into this death of Phoenix Sinclair. I had done research on this, which suggested kids in care, it's an incredible problem and across a whole series of dimensions. And so I had presented this to the ministry. They were supportive. I tried to get the inquiry to pay attention to this broader question. Don't focus on why this particular child died. Focus on this is part of a big issue. Absolutely no interest until my colleague, Marnie Brownell, had a paper published in Lancet which showed that Manitoba had one of the highest rates of taking kids into care in the world, compared with Australia, UK, etc. And she had an op-ed published in the Winnipeg Free Press and the Globe and Mail. The day it was published in the Free Press, she got a call from the inquiry. They wanted her to come in. They brought her in for a full day to present the evidence, and they broadened what they looked at. And we've had several examples of that. So I think that we do need to get the evidence somewhere more than into the Lancet, and although it's a great place to publish, but we've got to get it out there.
Thanks, Laura.
Craig Minton, UBC. Great to see you, John, and thanks for coming out this way. Just one quick note and then a comment to your question to us. I think sometimes, while this has been a fantastic day and a half, we have had a lot of Ontario-centric perspectives, and sometimes we forget that everywhere outside of Ontario has health authorities, and that's where 60% of the resources within the system are actually spent. And in some of our programs of research, like Stuart and mine, we've actually been very successful with our priority setting work around engaging public, engaging patients directly around identifying what criteria are relevant to those patients, to those public members, based on the values that they bring to the table, and using that within the system of health authorities to draw on their experience and then allocate resources accordingly. So just a general note on that. And it's not directed at you, John. That's just more generally around the day and a half. With respect to your question, I think it actually comes back to Jonathan's point in the previous session. I think you're right on with your first bullet on your last slide to say, if we don't have a burning platform, where is this going to go? And frankly, I don't think it is around the politicians. I don't think it is around our decision makers in the system, who many are in this room and who are good, smart people working in a complex, challenging system. I think it is around Canadians as a whole don't feel that burning platform. And I think that does speak to your first bullet point. I looked at my mother-in-law who died of cancer 2 years ago, stage 4 ovarian cancer, went through many problems in the system, but at the end of the day, she died. No big surprise. She had stage 4 ovarian cancer. We felt crappy about some of the process that went on for her, but she still died. And at the end of the day, we didn't have the energy to go back to the system. We didn't really care about going back to the system because we'd lost our loved one, right? And I wonder if, as people navigate through, grandparents or parents, and they see the cracks that are coming in, I guess this is my question to you, is it a Canadian value that we have collectively that says we just kind of accept it, and not in a bad way, not in an apathetic way that says, oh crap, this is like, my life's horrible, but it's to say, you know what? My mother-in-law died and we're carrying on. And yeah, the system has some problems, but we still wake up the next day. And I wonder if that Canadian value is part of why the burning platform doesn't really catch on. When we as policy researchers know that there are challenges in the system, we see where there are the gaps, but life goes on, right?
Yep. Point taken. Yep. I think we'll move on if that's okay.
I'm going to take chair's prerogative for 1 minute and just say it's fascinating to think that we are going back to the future in the sense that 50 years ago, if you had policy ideas, the place to go with that policy idea was a political party. That's where policy ideas came from. That was their role. That was their function. You think back to where did Tommy Douglas and the concept of Medicare come from? It came through a political party process. And in the last 20 years, we've forgotten that. And for one, we don't need to get into debating why, but for a whole variety of reasons, political parties are no longer really seen as the places that you go to as a citizen in order to generate policy ideas. And perhaps with the kind of thing that John's been doing, we start to go back and revisit that and start to see a political party is an appropriate instrument and vehicle for us to express new policy and develop new policy ideas. And so a testament to the forum for the work that it does on making itself available for those parties to have evidence-based policy development. With that, over to Heather. Your turn, Heather.
So my story is actually going to be a little bit more personal, and it's about my lived experience for 25 years working in the Ministry of Health, largely around evidence-based policy and trying to support that and champion that. One of the things that, as I was trying to kind of get my thoughts together about what I was going to talk about, I had a conversation with Victoria Shuckle, who's the executive director in the research department and has been there very many years, and we were brainstorming and we came up with many examples of, places where research had influenced or not influenced or had the situation had gone bad, but every example that we came up with, no, we can't talk about that in public. No, we can't talk about that in public. So yes, but and I think it just points to I think that a quote from Jonathan about the things you can't watch, sausage making and policy making. You also can't watch researchers working with policymakers. So, some of the examples I'm going to give are more about where I did projects that I worked on, and so I can take the heat for any failures that were part of the process. The other example was I am the co-chair of the Provincial Health Technology Assessment Committee, and I had it at one point. My job changed, and just recently I got it back. So we went to the first meeting again that I was co-chairing, and another one of my executive directors came with me, and she hasn't been very involved in the research process. She's mainly been involved in performance measurement in the system. But at this particular meeting, we had what I consider the finest evidence review that I have ever seen in terms of it was a very thorough analysis of the evidence, the strengths, the weaknesses. It placed it in context and what would be the other implications of this technology being introduced to the system in terms of other services, training, et cetera. We had a really, really excellent economic analysis that was done by Sterling Bryant. I don't know where he's sitting, but I know he's here, which actually, they actually had the patient care pathways, they costed them, they did different models for us of what would be the cheapest way, what would be the most effective way. It was brilliant. I've never seen such good work. And we couldn't make a decision. And the reason why we couldn't make a decision, or we didn't make a decision, was because the question for me has changed. And the committee is made up of people from the health authorities, researchers, ethicists, patients, clinicians. It's a large group, but very, and the discussions there are very thoughtful. But our question has now changed from should we do this to can we do this? We have all been burned in trying to implement new technologies where the system wasn't ready to take them on. And we have actually caused more harm than good by doing that. So we were clear that it wasn't, we need to go back and take a look at can we do it in a phased way. But I think, from my experience, the real question is how do we implement, how do we actually make this happen at a provincial level? And our system has a limited capacity to introduce change. It's hugely hard and difficult, and I'll talk more about that. And we can't do everything that comes along the pike to implement. So it was just, anyways, the story was my new executive director, who's new to this process, said, wow, I can't believe it. We had such good evidence. We had it so well presented. We understood all of the dynamics. But even with really strong evidence, trying to put it into a provincial system is not straightforward. So I think that, anyways, they were reflective of what I live every day. So Morris and I had an original title for this talk, but as I started working on it, I started thinking about this idea of Pilgrim's Progress, which my aunt had a copy of Little Pilgrim's Progress when I was a kid, and I used to love that book, and it was like a guilty pleasure for me. I was horrified by some of the things that happened to little Christian, but I also had that smugness that you have when you're 9 years old of why did he let his life get to be such a mess, and how did he get so influenced by people? And it just reminded me of my experience. And then when I went and looked at the book, the subtitle of that book is called The Journey from This World to That Which Is to Become, which I think is a good of my journey. Where that picture is right there is actually the Ministry of Health building, the BC Ministry of Health, 1515 Blanchard, where I have spent most of 25 years with some exits. And I actually came to the ministry, it is actually almost exactly 25 years ago. I came at the beginning of May 1991, and I had no interest or knowledge in working for government. I actually thought I was pursuing an academic research career. And I had a job. I was working at Western. I was doing half-time clinical practice and half-time research. My position was actually in the geriatric medicine department, but there was two things wrong with it. It was in Ontario, and it was where it was very cold, and it wasn't a permanent position. So I saw a position at the Ministry of Health in Victoria where I wanted to live. I applied. I got it. I came, and it was quite a shock to my system to come to work in government. And I was actually, I did think it was going to be like was like the work I did, the clinical research, where we worked together, the physicians, myself, the social worker, we all saw the same patients. We were doing research on trying to improve care for them. It was a very collegial experience. I thought that my work in the ministry would be like that, but on a policy level. I came to the research department, and the very first project I was given to work on was to develop an evaluation for the downsizing of Riverview, for the devolution of Riverview, which is our provincial mental hospital. And I went to, there was a committee that was working on this, and so I asked if I could go to the committee, and I was told, well, no, you shouldn't go to that. You're not, senior or important enough to go to that, and the research piece, just do it. And I just thought, like, really, how could I do an evaluation framework if I didn't even know what you were planning to do? So that was a bit of a challenge. I have to say that I only stayed in the research department for a few months. Sorry, I've got my speaking notes here on here. I don't forget it. The actual things do come back to haunt you. You realize things. The actual downsizing of Riverview didn't actually happen for another 10 years, and I'm not sure they actually ever did do an evaluation. But shortly after I came to the ministry, a few months after I came, report closer to home, the report of the British Columbia Royal Commission on Healthcare and Costs, which Bob Evans was one of the commissioners who wrote that report, and I was asked to go and work on one of the policy teams that was implementing the report. And I realized, all right, policy is actually where it's at. I could be very influential. By being able to write the skills I had learned as a researcher, to synthesize the evidence quickly, to write it down in a way that the policymakers could understand. And I was part of the table, and so I decided policy is actually where I want to be. And I never went back to the research department. I went into I did go back eventually. You'll see the rest of the story, but I did get this interest in policy because I felt that's where the influence can be. That's where you can have impact is when you're working on policy and bringing those relations to the people that are crafting the policy, including the politicians. One of the sad things is, and you've probably talked about this here, when the latest report came out, the David Naylor report on healthcare innovation, my staff, Victoria, dug back in her files and found a summary of all of the various royal commissions that had been done in Canada over the last 25 years, including the Royal Commission on Healthcare and Costs. And sadly, the same issues were brought up in almost every single one of them. So we have not made a huge amount of progress in this country. So I went and worked in policy for a few years. It was a really great period. I was working in the medical services plan with the Medical Services Commission. Big policy issues. We had a very close relationship with Bob Evans and Morris and others from the Centre for Health Services and Policy Research. I remember in those days we'd actually have meetings out at Dunsmuir Lodge, also no longer existing, where we would talk about policy. the senior people. I can't remember for sure if ministers came, but it was definitely the senior people to work through policy issues. And the big ones at in that time was physician supply, the beginning emergence of private Medicare, private services in the province. It was really an interesting policy time and greatly informed by this close relationship we had with the researchers. Again, then a downsizing came in the ministry, and I got put back in the research department. And one of the things that happened to me, and again, I felt like the research department was quite marginalized in the ministry. There was this uneasy relationship between research and the ministry and the bureaucracy. Yesterday, I was at a meeting with, and there was a Scottish, the chief scientist for the Department of Health in Scotland. And I also had an opportunity to meet with some of the people of the similar position from the Department of Health in England. And I was really really struck by how important science and how much more credibility it has in the English-Scottish system than it does in Canada. We have a very uneasy relationship with science, with academia here in Canada, and I think that does affect the uptake of research. Anyways, this very important paper came out, The Interpreter's House. I was told that if I called you, you would show me many excellent things, such as would be helpful to me on my journey. And this was the paper that Jonathan came out with in, I think, 1997 on the improving research dissemination and uptake in the healthcare system. It was a really important paper, and certainly for me, I remember reading it and discussing it with my staff and with people at CHSPR. And really what some of I went back to read it again when I was preparing this talk, and a lot of things that were talked about in that paper, which I didn't fully appreciate at the time, but now again, being older and wiser, I really see the wisdom of them. One of the things that he talked about was that both research and policy are a process, they're not products. And you have to understand those processes. They're entirely different, with different incentives and timelines in the two processes, but really advocated for early and ongoing involvement in the process of research, of decision makers being part of research processes, et cetera. One of the things he talked about, which I forgot that he had said, but I think is really important, was we have to focus on research synthesis of the entire body of research, or not, what do we know about a thing, not on a single project translation. And I think that's been forgotten because there is a lot of research translation and a lot of effort put into translation of single projects, and I don't think that's really very helpful to decision makers. We can't change the system in response to a single research study, and that's not really the way that science is done. So he actually talked about it there. The other thing he talked about was usable knowledge. There are certain windows of opportunity where a research finding actually can have an impact, and I think the work that John just talked about shows there are certain windows of opportunity, and you got to be ready to jump through those windows when they open, and you got to recognize that they're coming, and that's when you could actually introduce change and influence change. So I think it was a really good paper, and it was very influential. We used to call him our J-Lo. For the policymakers, J-Lo. He was a hero to us back in those days, and still is, of course. Following, and one of the good things that also came out of that work that Jonathan did was the creation of the Canadian Health Services Research Foundation, which really tried to put incentives in place for researchers and decision makers to work together. And this is just one example of a project that I worked on, and this is Entering the Palace Beautiful. And the thing about the Palace Beautiful that's important is it wasn't really that the palace was beautiful, it was that there was this fellowship and these women who were able to teach and educate Christian on things that he needed to know. And so one of the opportunities that came up was for people to apply for small grants to convene and create a research team to study some topic. And so I applied for one of these grants. It was like, I don't know, $5,000 or something very small, to study advanced nursing practice, because that was an issue that kept coming up. People were talking about advanced nursing practice, and I didn't really know what they were talking about. So I wanted to understand. People were saying we need advanced nursing practice. Well, what is it? I don't get it. So we started to do this project. One of the things that happened was when we put out a call, we sent out, letters to the nursing departments. nobody responded. Nobody wanted to work with us on this topic. And I have found that over and over again it's great researchers, when we're really specific about what we want, researchers actually don't want to join us. They want to create their own projects and do their own work. And so that interaction is still problematic. But anyways, I managed, because one of my old college roommates was in the Faculty of Nursing, I strong-armed her, even though it wasn't her area of interest or expertise, to helping me with this project. And so she managed to recruit some other researchers who were interested in this topic and were expert. And we also we brought together a team that included the College of Nurses, a number of nursing researchers, a health authority, and the ministry. And we did this research project. At the end of it, we had a forum where we brought together the key stakeholders in BC and presented our results and our recommendations, lots of buy-in and support for what we were proposing. From that work, we developed legislation, nurse practitioner legislation, that was very much based on the advanced nursing practice model and the recommendations that we had developed. New funding programs were put in place to train nurse practitioners. I thought this is a perfect example of what Jonathan's talking about and how we can work together and really, drive evidence-based change. Following the Palace Beautiful, I don't have a slide, is the Valley of Humiliation. And my Valley of Humiliation is, 20 years later, however many years later from that experience, we still don't have nurse practitioners very effectively integrated into our system in BC. And I know that Bob Evans will know the answer to that, is because the whole issue of payment, it's about a salary issue. Any money that we give to nurse practitioners is taking away. It's always about someone's salary. And it wasn't that we were naive to that when we did that project. We just didn't understand, or I totally underestimated how hard it would be to break that reality of the physician's stranglehold on primary care money. So a beautiful experience followed by what so often happens. At a later point in my career, I had the opportunity to go and work at the Ministry of what it was called Employment and Income Assistance. And my responsibility was overseeing regional operations, so all of the offices for income and disability assistance. And it was a really great experience, but one of the things that really struck me was how, as imperfect as our evidence-based system was, they actually totally lacked one. They didn't use evidence at all. And it's a very different system. Healthcare legislation is very enabling and not prescriptive. They had very prescriptive legislation in which you could not give anybody a benefit unless it was actually identified in the regulations. So over time, partly in response to some fairly draconian changes that had been made as part of welfare reform earlier, when an exception came forward, you couldn't give it to somebody unless you made a new regulation. And so as a result of human rights cases, or even just the fear of human rights cases, new regulations were put in place. So there was this very complex legislation that frontline staff had to go through to consider. And so just for one example, one of the things that when we were looking at our budgets, we spent a lot of money on really high-priced running shoes and orthotics, because somebody had once made a case that they needed orthotics. And so now there was a regulation that allowed you to have orthotics. And so we had, these people that didn't have enough money for food running around in really expensive Nikes, and because that was the regulation. So I realized, okay, evidence is not easy, but at least we have one in healthcare that we're trying to emulate. And I even brought Sterling Bryant, that was when I first met him, to come and help us sort this out. Unfortunately, my efforts got waylaid by the economic downturn when we were just, trying to respond to the need that was coming at us, and I didn't make much progress at that ministry to change their evidence-less state. But I also want to say, I also have although I actually question whether I should use the Vanity Fair, because in many ways it was a wonderful ministry. The people that worked there, I had huge respect for them, and working with the most vulnerable in a population that, with frontline workers who had huge responsibilities, giving out over $1 billion, trying to follow this very arcane and complicated legislation that they were required to use. So it was and sometimes I think of the quote, sometimes it's better to be nice than to be right. They really led with their heart, and so that was also really important. I got called back to the Ministry of Health, and my job coming back to the Ministry of Health was to be the responsible for the Health Authority Division, which was, and the ministry had just come out with the Innovation and Change agenda, and my job now was to implement what was parts of the Innovation and Change agenda. And indeed, saying and doing are two different things. So when you ask why we don't implement your great research ideas, it's damn hard. And it takes a lot of work and persistence. One of the ones that we were working on in particular was clinical care management, which was trying to bring evidence-based. I'm going to just skip over that because I'm going to run out of time. But it was really, how do we implement something on a provincial level beyond a pilot project, beyond a good idea, to actually get the change to happen? And it was really hard. And we did. So after all of this in my career, I still believe. I still believe in the vision and the idea of evidence-based. I'm still standing on the Delectable Mountains, and if you look in the distance, you can see there on the mountains is our SPORE support unit and our academic health science network, and that's where we're going to get to, where we'll finally get the nirvana that we're looking for. So, just coming back to the health system and the research enterprise and the interface between them, I think we've learned a lot, and in some ways we haven't learned anything. The challenges that were so well laid out by Jonathan all those years ago still remain. We still live in different worlds. We still have different incentives. We still have different needs and perspectives on the world. We've talked about research push and we've talked about research pull. Some of the things that I would take away from that, just to quickly answer the question about what kinds of things, how can researchers have impact. Two of the things that I find particularly useful have been, again, going back to what Jonathan's, a systematic review. When we're going into a new area of policy development, to have somebody give us a neutral summary of what the evidence is, the state of the evidence, not an advocacy of this particular policy position or that, but just a neutral, this is what the state of the science is. And the work that John does at McMaster, I have to just highlight its excellence. We just recently asked them to do a rapid review on mental health, because we had this impossible situation where the people that were working on it, they had 5 days to get something before cabinet, and they wanted the research synthesis of the evidence, and they were just about to go out and, get a contractor to do a